always, after his presentation, we'll do some questions and answers. And at the very, very end, if you'll not come up on this stage, so we don't want anybody falling onto the hard surface, he'll go out to the foyer and be happy to answer any personal questions short of full medical consultation, which he can't give at a place, a time like this. He did not bring cards. I have a bunch of his cards I'll bring to our next meeting, but do you have your contact information on the screen? So those of you interested in contacting Dr. Grimm, make note of how to do so, and I'm sure he'll be happy to talk to you professionally. Without further ado, Dr. Peter Grimm.
Thank you, Larry. Well, it's truly an honor and privilege to be here. First of all, to be warm. That's being in Seattle, we had a nice snowstorm last week, and it's nice to be dry out a little bit. We've got a lot to talk about tonight, and what's exciting about talking to all of you is that, and putting this in perspective is that all of us are related to prostate cancer in some way, and the folks here who've been treated have made decisions based on the information that was available to them at the time and made the right decision for themselves. And some of you have not yet made a decision about what to do. And what we're going to talk about tonight is about new information that I think will help more men make a better informed decision about what treatment they might want to consider for themselves. So we're going to talk tonight about some updates of the prostate cancer results study group. We're going to talk about some role of testosterone. I know that many of you are interested in prostate cancer management and after treatment and before, and some things about the new PSA screening controversy. And then if we have some time, we'll talk a little bit about some new developments in brachytherapy, which I'm very excited about, which are going to make these even better. Let's talk a little bit about the prostate cancer results study group. I think we formed this group, which I've had the privilege of leading, about 3 to 4 years ago. And the intent is as many of you have experienced in the process of learning about prostate cancer, is that it's difficult to understand what the results are, and then to compare one result of one treatment to another is almost impossible by looking at the available information. And every website has its own information, and most of it's directed towards the treatment that they want a patient to get. And so the intent of this was really to answer that question, what treatments are, what are the treatment results, and do it in an unbiased fashion. Now I'm a pioneer in brachytherapy. If I did it myself, it wouldn't be a particularly unbiased study. So what we did is I asked experts, and every single expert I asked around the world agreed to participate, which I thought was remarkable. This included experts in brachytherapy, surgery, external beam radiation in its various forms, IMRT, proton therapy, etc., and HIFU. And I asked them to participate in this process. First of all, how do we compare studies? And they've participated. There's over 25 of them. And when you email me, I will send you this entire slide set so that you can look at it carefully for yourself. And you can see who the people are involved. But these are experts, all prostate experts, from almost the major cancer centers in the world. I'm very proud of that, and one of the ones I'm most proud about is my daughter, who was forced into this and to help me, and she's now just finishing up her residency. And what we did in this study was very simple. It's a very simple concept. A lot of things that are simple concepts are hard to do. We reviewed over 18,000 articles that have been written over the last 10 years. In those 10 years, 848 articles would be identified as being treatment-related. So these are articles that have just dealt with treatment results, surgery results, external beam results, any results. Those are the articles we wanted. From that, we then looked at those. We looked at those articles, and the experts all agreed on these criteria for inclusion of an article that could allow the article to be compared with, or one treatment to be compared with another. Very simple. I suspect many of you are familiar with the stratification of patients into risk groups. Low, intermittent, high risk. Paper had to do that. It had to had to be analyzed by PSA. Now the reason PSA is a useful tool is because it's very sensitive. It tells you whether the treatment was successful or not. Actually, survival is not a sensitive tool. For example, if a man had surgery, or two men had surgery, both of them could be alive at 10 years. But one man could have had failed at 5 years. And we would say, if you looked at survival, you would say that surgery was 100% successful. You see the problem. And then somebody else would say, no, the surgery was only 50% successful. So that, when any of you look at survival as an endpoint for looking at the results, you probably shouldn't use that. You should use PSA, because PSA is your most sensitive tool to see whether treatment. I think what every man wants when he gets treatment, if he gets a treatment, he doesn't want another treatment. That's what this is going to look at. All the treatments were considered. We couldn't have any bias in that, and they had to be in a peer-reviewed journal. So they had to be reviewed by experts. They had to have at least 100 patients. And here's the other one of the most important things you should understand about looking at any information that you look in your group. You should not, it's okay to look at papers that have follow-up less than 5 years, but it has very little meaning. The reason? Everything looks good under 5 years. Let me repeat that. Everything looks good under 5 years. What you're interested in, you should be all interested in, is what are the long-term results. Where things start to sort out is after 5 years, and that became abundantly clear in the slides that I'm going to show you, is that these treatments don't start to really sort out until about 5 years out. And many of the newer treatments are reported out at very early periods, like 3 years, and you get great results. Unfortunately, what you hear is that, oh, we get 95% control rates. And that is way too early to be analyzing the results. So when you look at stuff, if anybody brings a paper to this group, if this doesn't have a 5-year or longer follow-up, you probably should put it at least over to the side or in the trash. Because it really is not going to have should not have a lot of impact on your decision making. And that was agreed upon by all the experts in the world that looked at this. Only about 17% of the articles actually fit into these categories. So there's a ways to go. There's a problem in the literature reporting is that basic information is not included in every article. The other maxim that you should be aware of when you look at information, bad results are not reported in the medical literature. Let me repeat that. Bad results are not reported. If you don't see a lot of articles long-term out on the treatment you're looking at, there's a reason for that. Because if there are good results, you can bet your life they'd be published. Does that make sense to everybody here? Yeah. And you'll see in some of these that there's not a lot of studies out there in some of these treatments. And that's a problem. Nobody wants to go out and say, I'm a bad surgeon, I'm a bad radiation person, because it shuts down your business the next day. So I think all of you, if everybody here familiar with the risk stratification systems, low, intermediate, high risk? Most everybody here? Okay. I won't spend much time because we want to spend more time on the slides and some of these other things we're going to talk about. Here are the results for the low risk group. Now these slides were made, and again, they're all available to you and they're updated every 6 months. So if you give the email to Larry or whoever you'd like to, and you get them to me, I will put you on this list where you get a constant update every 6 months on these results. Pretty easy to understand. You notice there's dots, there's blue dots, there's green squares, red triangles. All the blue are seed implantation articles. All the red are surgical articles, and all the green are external beam, like IMRT. So what we simply did was we determined what the result of the study was by PSA. On the left here is 100% control, as you can see at the top. And the bottom is, the number of years the study was out. So not too complicated here is that, for example, this is number 14. Article number 14, which is down in the note section. Brachytherapy at 11 years in this study, 97% of the patients were controlled with just a seed implant alone. Here's the table here that explains what the symbols mean. So it was a simple matter, very tedious, but a simple matter of placing all the information on one slide for all the low-risk patients, all the low-risk articles. I don't know if any of you have been through this process of trying to figure out if you're a low-risk patient, to try to put everything all in one place. It's a very hard thing to do, but this is a visual way of doing that. My British colleagues then did a statistical analysis of these results. Now, all of us are aware that randomized trials are the most reliable tools or reliable studies for finding what the truth is. Excuse me. This is... Bear, don't give me a thought. I'll have to call you back. Okay, I'll talk to you back later. Okay. Sorry, my partner, I have to answer their phones. Thank you, sorry about that. In these studies, what we showed is that if the truth is probably lying in the middle of all this information. So in the absence of a randomized study, we have to rely on the information that you have available for you that day that you got it. And so if you look at this, a couple things that are interesting about the low-risk group is that here's the brachytherapy patients here, clustered here, with an average sitting probably around 92% long-term control. This is about beyond 5 years. The curve is flat. It's not downward sloping. The external beam approaches, there's a slight downward curve after 5 years. This is why I mentioned that it's very important to have long-term, because some of this fall-off starts to occur after 5 years. Like IMRT is expected by Mike Zaleski's at Memorial Sloan Kettering to have 81% long-term control at 10 years, versus a seed implantations, which is 93%. So these things can become very important. So you can see trend as well as you can see the trend over time. Surgery is kind of heading the same way. Now the good news about all this, though, is one thing. If you look at this slide from the 30,000 foot view, what you can see is that 80% of the patients are going to do well no matter what you do. So the good news for most patients who are in the low risk group, is they really can't make a bad decision about treatment. And that's what I tell most of my patients, you can't make a bad decision. So this is good news, but it's sorting out this information. Now some of the people said, well, there's not enough studies there to make a really strong decision. I said, okay, well let me just relax the criteria slightly, just use 40-month rather than 60-month criteria. So studies that looked at patients beyond 40 months were included now. And this is what we came up with. See a lot of clustering, a lot of things everybody doing real well here at 5 years, but again, the trend is downward, and downward surgery, and seed implantation is fairly flat. It's very rare that you see a failure after 5 years after seeds. So that's, this paper, by the way, is being published this coming month in the British Journal of Urology. So we looked at each group like this. We then went to the intermediate risk group and looked at them and see how they did. Now, what you would predict with treatment is this. It's not very complicated. As disease becomes more aggressive, the more chance of the disease outside the area of your treatment, of a local treatment. So surgery, which has the tightest margins of all the treatments, because remember, you're trying to spare the nerves typically, it would be expected to fail more often as the disease became more aggressive, the higher the risk group. The more disease, the higher the grade, the higher the stage, the more likely a finger of cancer is out beyond the area. You can think of it like this. This is, your hand is a prostate, and inside that is a prostate cancer. These fingers are the cancer that spreads beyond it. You have to treat all of it to get all of the cancer. Now, fortunately for most prostate cancer, the lymph nodes are really fairly low risk today, because we don't allow the cancers to get to very high stages and grades now because of PSA screening. So if you treat that area, then what are the treatments that are going to cover that? Well, surgery is going to be the tightest. Seeds might be the next level, and combination of therapy would be a little bit wider of extremely plus seeds. And what this looked at is those different treatments. And actually that comes out to be not too far off of what actually we see. The local therapy, the most local therapy, has the worst result. Surgery. Now whether you do robotic surgery, I'm sure somebody's talked to you about this before, whether you do robotic surgery or the retropubic prostatectomy, there's no difference in cancer control rates. Does anybody have any questions to that statement? If you find articles different to that, send them to me, please. There's no difference in cancer control between those two kinds of treatments. These are mostly retropubic. There's actually very few robotic surgery articles out there, which makes me kind of wonder what's going on. Here's the combination group that got extremely plus seeds, and this other circle here is kind of blue. It's a little hard maybe for you to see that, is the seed implantation alone. They sort of overlap. And here's the external beam again. External beam radiation is failing after 5 years more often as a sole treatment. The reason surgery is going to fail is simple. Disease is beyond the area of beyond. They've cut through the fingers. They've left cancer behind. It's simple as that. It's predictable. You can predict it by the Parton tables. External radiation is going to fail because there's not enough dose, because it gives enough area, it treats all around that whole area. But it's going to fail because there's not enough dose. Seed implantation inherently would be predicted to do better because it gives a higher dose to the prostate for radiation, and it treats the area beyond it. And if you think you need a little farther up, say, for example, in some vesicles, then you're going to be able to even get those fingers. So many of these, this is our studies are out here, out of 15 years. They're very high control rates with combined therapy. But we know that there's a select group in this intermediate group that just get an implant alone. And we don't have time to go into those specific subcategories, but know that if you get evaluated, it's very possible if you're in an intermediate risk group that you could do an implant alone and do just as well as with combined therapy. But the overall is that some more aggressive therapy with seed implantation or combination does appear to be superior to external beam or surgery. Now this is not me talking. I'm talking as representative of this body of experts. I think this is going to change some minds here in the near future about what the right therapy is. Here's when we looked at the 40-month curves and see if there's any difference. Same thing. It really didn't change much of the curves at all. And the ellipses that were drawn on here. Lots of data now on here. Here's all this 5-year data that's all here. You can see everybody likes to stack up and report 5-year data, but it's really out here it's really making the difference. Also true is what we weighted these ellipses by the number of patients in an article. So an article that had more patients could change the shape of this. Just to make it more statistically valid. Now, where the area that I often find some of the controversy, at least in people's minds, is that high-risk disease. The statement is often say, well, you have this high-grade cancer, you got aggressive cancer, therefore we got to be more aggressive, therefore we need to do surgery. It makes no sense at all if you really look at the Parton tables and other tables that look at the disease outside the gland. Because it's not the disease that's in the prostate that kills patients. It's the disease that's outside the gland. You've got to cover all of the disease if you intend to cure a patient. It's predicted that a high-risk patient has at least a 50% chance of having disease outside that prostate. Why would you pick a treatment that's got an immediate 50% chance of failing, predicted histologically? Well, when we looked at the studies on this, that's exactly what we found. Is there's at least the long-term PSA control rates are only 30 to 50%. Now the surgeons will often say, well, we can give you post-operative radiation. But the reality is that there's been no studies to show, particularly in the high-risk group, how well those patients do. We don't know. No studies. There have been salvage studies that show there's about a 60% salvage rate if you've got positive margin, positive PSAs and stuff like that, with getting radiation after, but almost all those are low-risk patients. There's none of the studies that have been in the high-risk group. So, external beam shouldn't be expected to do better either, because, again, there's not enough dose there. There's not enough dose there to control those cells. You got to give a high dose. Problem with giving up above 81 grays, you start to give more dose to the bladder, the rectum, and the hips, and you can start to get long-term side effects to that. You really want to try to avoid that if you can. The best combinations for the high-risk groups now will appear to be a combination of external beam seeds and hormonal therapy. We started doing that about 8 to 10 years ago because we saw this. And the nice part about this is that the radiation, external radiation, doesn't include the pelvis. We're getting results here, sitting here, anywhere from, on average, about 80%. Some of them are even higher, 80 to 90% with this combination. And we're not even having to treat the pelvis with radiation. So it's really good news. I mean, really exciting news, I think, for everybody here, is that for high-risk disease, when I first got into practice, my external beam results were terrible. They were down here. They're sitting down here. 40% of my patients that are treated were being cancer controlled with those doses I was using. I mean, in my short career here, 20, 25 years, I've seen an improvement of almost 50%. That's pretty darn exciting. So, and this is all of the information that we have that's available. And I would ask you, if any of you are interested, you're all interested to look at all the studies, to add studies. If you find something in the literature you think that needs to be reviewed, we put it through the same filter and it goes on the board if it's valid. And this is a collaborative effort. This is, open source. We feel that we're all together in this process of trying to understand this. All of us puts a little energy into it. We'll all be able to analyze this in the same way. The other thing I think could be very powerful is that we need to force our researchers to report in a similar way. They need to report simple things, PSA results, put them into risk groups, and give me data beyond 5 years. How hard is that? Just give me the basics. Yes, sir.
Could you comment a little bit further on the value of adjuvant hormonal therapy for any of these surgeries?
In some of the earlier slides, there's not a lot of hormonal therapy data that's in these groups. In the studies that have looked at it, when you've used seeds, if you give enough dose, you don't have to use hormonal therapy in low and intermediate patients. There's probably some slight advantage in high-risk patients. These diamonds, see this diamond here? These are patients who just got external beam plus seeds. These patients got the hormonal therapy, so there's probably a little benefit to it. That's why they get it. But they only have 6 months. It's not long-term. I don't believe in giving 3 years and all that kind of nonsense. I just don't think it's beneficial typically to patients because it really affects their lives. And we'll get into that when we start talking about testosterone. But that's only 6 months of hormone therapy. That's 2 lupron injections. So the guys get out of it pretty well. But you can get just external beam. If you don't want to have hormonal therapy, you can actually do pretty well with just a combination. Okay. So in conclusion about this work is that for most low-risk patients, most patients will do well no matter what you do. 80% will do well. So look at look at how much disease is there and how much. Yes.
At the risk of being maybe repetitive here, but
Yep.
when you say, that no matter what you do, you're working with expert doctors, okay?
Yep.
What was the question?
He's saying you're working with expert doctors.
When you say that the therapies are equal,
Yes.
this may be, you're talking about maybe represent 200% of all the,
Yes. These are the best of the best.
these are the best.
Because they're the only ones that report.
So if you go to a corner doctor or something like that, you probably won't get the results that you're getting.
Yeah, you don't know. I mean, that's true. I always tell patients that you're dependent on the skill of the person in front of you and their experience. Now, one of the things that I have a company that does a quality assurance on their brachytherapy, called Procura, in which I review every single one of those guys, of those people's and women's implants.
I did a little research in this area, and I found that there was a study by New York University.
Do we have a microphone? I don't think so. Okay.
Sloan Kettering, yeah.
And it compared doctors that implemented C's that had at least 200.
Larry,
Yes.
could you stand up and speak up?
Nobody can hear.
Try your question again.
They compared,
You don't have a microphone, unfortunately.
They compared doctors that had implemented at least 200 patients with C's.
That was
Or-
there was a surgical study that did that from Memorial Sloan Kettering.
Yeah.
I'm not aware of a seed study that's done that, but I
Yeah.
know a surgical study looked at their surgery within the Memorial Sloan Kettering system. They looked at the performance of the surgeons and the overall result and showed that there was a difference
That big difference.
based on the number of cases they
Yeah,
had.
yeah. The study that I reviewed was C's.
If you see that, send it to me because I haven't seen it.
Okay.
But it's true. I mean, experience does count, I think, in anything you do. So this is always looking at the best of anything. But relative in a community, if everybody has a relative experience in their own area, the ratios probably be similar. Yeah. Yeah, that's another issue. The good thing about seed implantation is you can tell immediately afterwards how well you did. And by looking at the dose distributions, we do CAT scans afterwards, and that's standard, calculate the dose. And you can calculate how well that person does compared to me.
Could you explain that?
Well, afterwards, after an implant, we do a CAT scan to look at wherever every seed is. The computer then calculates a dose from that seed, from every single seed in that prostate, calculates the overall dose and gives us a very detailed mapping of it. And we can tell by that mapping whether that implant is a good implant or not, based on some basic parameters. And compared to my results and some of the others here that you see on the slides.
So you'd be comparing your plan with the actual...
With the actual original plan. The post-op, we call it post-op dosimetry. So you compare what you planned for with what you achieved. And it is important that you get consistency there. We know that there's some cut points where below which you achieve, the chance of failure is going to be a little bit higher. So, and that can be, that's every center now does analysis of that. So they should be getting better if they're not good already. Yes.
If you have two,
Hold it. If we're going to ask questions, need a microphone.
there you go.
The audience is,
But let me just ask to keep the questions brief now so the doctor can get through his presentation. And at the end, we can, if you can keep a note of, Marty, go ahead, but after this, let's make note, and then we'll have a Q&A at the end so we can get through his presentation.
fair enough.
Yeah.
But no cues without a microphone. Who's that, Marty?
Yeah.
There you go, Dr. Weiss.
Marty. If you have two seed implanters and their dosimetry is adequate, whatever it is you call 80, 93, 97, whatever.
Right.
Let's say they both are adequate by your criteria. Should they then therefore get similar results?
That's the assumption.
Is that, do you?
I think that's logical.
Thank you.
Say like if you're a medical oncologist, you gave the same regimen that the experienced guys did, you should get the same results.
So the reason why this is of importance is because the notion that there are only 5 people in the world who do it, it wouldn't be true. But you would want to somehow get a measure of people's dosimetry in their hands.
Right.
And if someone, you're saying, I believe, if someone has the record of good dosimetry, like if you're a procurer, if you're reviewing them and they have good records, you would assume they would get good results.
They get a certificate of year saying these people are qualified, they've met the criteria for excellence.
Thank you.
Yeah, no, I think that's important.
Larry, you get one more.
Yeah.
But you got to speak up. Somewhere this on switch there.
Yeah, the problem is a very small percentage, okay, gives cure rates, okay? And so typically the experts are the ones that participate in studies
Right.
where you can see what their cure rate is,
Right.
okay? And if you're newly diagnosed and you're trying to make a decision where you go, cure rate for most people is probably one of the most important things. So documenting cure rate is essential in making a good decision.
Can be. But I can, having trained a lot of folks around the world, I can tell, I mean, look at those dosimetry, I can tell, and I work with them. And if they're hitting these marks, they're gonna get as good results as I do. And I've seen this out of community centers, community hospitals, tiny community hospitals. Guys, as long as they hit their mark, they can get just as good results. So, I'm encouraged by that. That's the other, it's important. I think we don't have time tonight to talk about side effect profiles, but that might be a subject sometime in the future that we talk about. But they have to be considered for every patient to make a decision. And relaxing criteria or including more studies into this, so far has not really changed these curves at all. And I'm anxious to see how it goes over the next 5 years. And again, you'll get updated every 6 months and see if there's anything's changed. Now, if you'd like, these slides, a slide that's more detailed that was created by us too, by the national group, I will send these to you. And it's peter@grimm.com is my email. Real easy. If you can't remember, it's real easy. It's peter@grimm.com. Okay, let's go on to the next subject. And let me give you a case scenario, which is a real case. I had a 68-year-old physician who was diagnosed in October 2003 with high-risk prostate cancer. We gave this guy a combination of therapy, which included hormonal therapy, external beam and seeds. His cancer was controlled. But he was complaining of generalized tiredness. He just was not feeling very well at all. Did a testosterone, and it was low. It was what they call hypogonadal, which means he's lower than the normal range. His PSA limit and his PSA limit indicated his cancer was controlled. So what do we do? Well, at the end of this little discussion, you're going to tell me what we're going to do. First of all, what is testosterone? Many of you know quite a bit about this, so if it's not understandable, just raise your hand and we'll talk a little bit more about it. But testosterone is a steroid hormone that is primarily produced in the testicles, but some is produced in the adrenal glands. It has a very, very important function for multiple functions in the body. It promotes the enlargement of the prostate, it helps the testicles produce sperm. It's important in muscle growth, brain function, cognitive and memory, bone strength, erection ability, red blood cell production, insulin metabolism, and the basic building block of this is cholesterol. And so when we're always talking about lowering our cholesterol, one of the ironies of that is that lowering cholesterol is a basic building block for testosterone. That doesn't sound too good, does it? What's the history of using testosterone in prostate cancer patients? Well, historically, testosterone has been avoided. And it's been avoided because of this fear that you're fueling a fire. That started in the 1940s, Dr. Huggins, who noted that when he castrated patients with prostate cancer metastatic, that it regressed. The corollary on the other side of that would be is that if you gave testosterone, it would stimulate the cancer to grow. And in fact, with patients with metastatic disease, it could do that. But this data and all this stuff was only based on one patient. But that got set in the medical mindset of every single physician, every medical textbook, for years and years and years to come until just recently. So if you talk to your internists, almost anybody you talk to, what they will say is that if you had prostate cancer, oh my gosh, you can't have testosterone. That's not the truth. And that's why I wanted to bring this new information to you, so you can start to think about it and give you some information to start to read about this subject. I think it's very interesting. First of all, what are the symptoms of low testosterone? Now, there's questionnaires out there now, 10-point questionnaire that'll kind of give you a clue about it. But some of the things, low sex drive, low energy, erectile dysfunction, decreased muscle mass, falling asleep after dinner, less ability to normal physical activities. All these things can be symptoms of a low testosterone level. 45, well, I just gave the answer, Turn. I was going to ask you how many men, after 50 years old, how many men do you think have low testosterone? Well, it's about 45%. Testosterone levels gradually decrease as we get older, starting at around 40, 45 years old. So many, many men have low testosterone levels who don't know it. Why don't they know it? Because it's not in the standard chem screen. You have to order it specifically. A lot of docs don't do that. Your insurance don't do it. Why? I don't know. Testosterone, which is produced again in the testes or adrenal gland, is converted in the prostate to another agent called dihydrotestosterone, which promotes the prostate to get large. That's why the prostate gets large as we get older. Some of you have you heard of Avodart? Some of you heard of Avodart? Avodart blocks that. Allows the prostate to shrink back down. Because it blocks that conversion in the prostate. That's why it's nice to help guys pee better. It also helped guys grow hair. Started out, that's how they first found out. Because guys started to pee better, and they got hair in their head. And that's what Propecia was. But then so you increase the concentration, and that's how that got started. This testosterone is similar. The reason it can be important for your strength and energy, this is the same. Testosterone is just is an anabolic steroid. It's much like these athletes and stuff like that. They're all using derivatives of testosterone to build their muscle strength up, and they're responsible for a lot of muscle strength and bone strength. Bone strength then comes from the muscle pulling on the bone, and you get stronger. Okay, and if you take away testosterone, you get low, muscle strength and bone loss. And generally, what you often see on guys is that their abdomens start to get a little bit wider. They get that sort of gut. So it definitely affects the quality of life as we get older. It's one of the more important reasons for a poor quality of life as we get older is the lower testosterone levels. So it's a very important topic for all of you to understand. And I think it should be a topic of one of these meetings for you. So, everybody should talk about it. Because it can affect you. So, can any of these treatments cause low testosterone levels? Well, generally not. Although there's some studies that suggested that there's some changes in testosterone level after these treatments. It doesn't permanently decrease in testosterone levels. At least, either the radiation or surgery or any of these treatments that treat just the prostate. There's no reason because the hormones produced in the testes, which shouldn't be effective. Prostate cancer itself, in a few studies, showed that it did lower testosterone by itself. So it may be an independent factor. So, all of you are familiar with Lupron and these other agents that block testosterone production. And these agents just stop the production by the testicles. Most of the prostate cells are testosterone sensitive. They're sensitive in that they will stop production of PSA, and that some of the cells themselves will actually die without testosterone around, but not all of them. And certainly not cancer cells will all of them die. That's why it's not a treatment in itself. A lowering of PSA does not mean cancer cells are dying. You have to understand about Lupron. It's a good sign, because it's putting these cells probably, at least most of the cells, in some sort of quiescent stage, but it's not all the cells, first of all, may not be sensitive to this, and it cannot be assumed that simply because the PSA drops down with hormonal therapy that the cancer is gone, or decreasing in numbers of cells. It just turns down the rheostat, turns down the light, so not as much PSA is for most of them. All right. So, what do we do? If those guys in men who have not previously been diagnosed with low levels of prostate cancer or low levels of testosterone, are they more prone to prostate cancer? Yes. those men who have no history of prostate cancer, who have low level of testosterone, there's a slightly greater risk of developing prostate cancer if they have these low testosterone levels. If the testosterone level is low, that is more likely that cell is going to be more aggressive. Now, there's been lots of speculation of why this is. It may be simply that those cells that show up, they're not hormone sensitive, and they're more aggressive. But I don't think we really understand that. All right. If you don't have PSA, and if it's low testosterone, it increases the chance that I'll get prostate cancer. This again, the same question. There's at least 11 trials about this. None of the studies demonstrate an increased risk of developing either prostate cancer over a normal population or higher grade than those that did develop prostate cancer. Other studies of note have found no correlation of a high testosterone level and the risk of prostate cancer. So having a high testosterone level does not assume that it's going to stimulate a cancer from developing. Can somebody lower that down? I want to get that whole question. Let's see. Just lift it up just a little bit.
Move the table back a little closer.
Just lift up the back part of it so I can see the bottom part of that question. I want to make sure I got the right question. Okay.
More?
What is, no, that's all I need to do. No, just go back to where it was. That's fine. Okay. Just set it back down. That'd be fine. All right, let's talk a little bit about how testosterone works. Prostate cells there's receptors on prostate cells that are influenced by testosterone. Testosterone then fills up these receptors. Okay, so let's say we just have one receptor on a prostate cell. Testosterone is floating around, attaches to that receptor, and that's it. Can't let any more testosterone on top of that. Much like if you gave water to a plant, the plant's not going to grow faster if you gave more testosterone. So if you're a guy with prostate cancer and you have relatively even sub-levels of testosterone, like say maybe 150, 200, your receptors are very likely completely filled already in your prostate. Does that make sense? All those receptors are filled in the prostate. Giving you more testosterone, which may be necessary for your cognitive function, your red blood cell production, your energy, your bone strength, all these other functions, is not going to hurt that prostate. Because it's not going to stimulate, you've already got testosterone floating around to stimulate this growth. Does that make sense? So if you've already got a stimulant there that's already circulating around, if you're going to have recurrence, it was going to recur already. So a reasonable time after treatment, it's reasonable to give guys supplementation. That's the point. You can get supplementation, with gels or shots or whatever, of testosterone after prostate cancer. Number one, probably if you had seeds or something like that, you killed all the prostate cells anyway. And number two, the circulating testosterone that you have already is probably filling up those receptors, and it would have stimulated the cancer already. So giving you some more testosterone is not going to make any difference whatsoever. Does that make sense? But that's not so the bottom line, by adding more testosterone, does not affect any more cells, and you can do this safely. And I have probably 40 patients now on testosterone supplementation. It can make a dramatic difference in men's lives. And I had one guy who was 82 years old, started on testosterone about a year ago, and he came in, and I said, well, what do you think? And he says, it's made all the world of difference to me. And I said, how so? He says, I go out down and I go down, chop down trees all the time. You're out there chopping trees down? This guy's 82 years old. He's out there chopping trees down in his house in the woods. That's pretty darn good as far as I'm concerned. If you can do that, I can't do that. So I'm proud of him. So is it going to affect your PSA levels? It's possible it could affect the PSA levels. But I've had, of the 40 I've had 2 patients so far. It's bumped it up slightly. I stopped at the PSA, but A. Morgenthaler, who's a Harvard professor that I've been working with on this subject, says that he's had that before, and you don't necessarily have to stop it. But right now I'm stopping it until I find out a little bit more about that. Will testosterone reverse your urinary function? Not that I know of. I haven't seen it yet in any of my patients, so we'll take a look. Will testosterone increase the risk of prostate cancer coming back? There's only a few studies that have given testosterone in hypogonadal patients after radical prostatectomy. None of the patients developed a PSA recurrence, despite the fact that these men were supplemented to up to normal testosterone levels. So I usually, when I supplement guys up to normal testosterone levels. All right, we've talked about this, about the fact that it doesn't increase the chance that he's going to grow it. So. And I think we already discussed the fact that increasing it up to normal levels did not apparently increase the chance that the cancer is going to come back or developing prostate cancer. Okay, so the bottom line in terms of the testosterone supplementation is I think it can be given safely to patients who've undergone treatment. I do delay the implementation of this for at least 1, usually 2 years, so that I have a good sense of if their cancer is controlled. I would recommend, if any of you that are interested in that, you read this book, Testosterone for Life, written by Abraham Morgenthaler. Very good book, and very easy to read, to understand all of this. Okay? You want to keep going? You can stop there and ask a question?
We'll need a break at the tape to switch cassettes.
Okay. All of you, do you want to take a break now? Take a little break? All of you who've had a prostatectomy can go. The guys who've had extromium can go an hour from now, and the guys who've had xenoplastia, you can wait till the end. Yeah, joke. Sorry, I have to help for that. Oh, you guys want to keep going?
Usually you're good for another 12 minutes.
Okay, let's go on to the. So what did we do with the guy? What did I do with the guy when we started with this? The physician. We started him on testosterone supplementation 4 years ago. We've closely monitored his PSA. His PSA is disease-free now, has normal testosterone level, and feels much, much better. Yeah.
Is normal relative to the individual?
Thanks. That's a good question. There is a range out there of testosterone levels that ranges from 250 to about 800. Kind of depends on which lab you're looking at. But every man is slightly different. So I would recommend, if you're going to consider this, even for long term, that you get a testosterone level now, so that you know later on if you're going down or up. Because a normal for one guy may be 700, another guy may be 300. And the change, a guy going from 700 to 500 could be a significant change for him, and he may benefit from supplementation. So most of us probably should have testosterone levels when we're 35. Then we know what our normal is, but we don't have that, so we have to kind of guess.
About this concept of bioavailable testosterone, available saliva as opposed to serum testosterone.
Yeah, and you can start getting into measurements like that to see, and if you get into questions like that, you can do that. I haven't, in talking to Abe and stuff like that about it, he hasn't been doing it routinely. Because you just kind of measure their response, and you find out if they get better, they get better. You watch your PSA, that's what you're really worried about. And if they don't get better, then you just stop. You know, if you push it up a couple hundred points or get it up in the normal ranges, you'll get a benefit. You don't. But you can do fancy stuff like that too. And I don't typically use it. Any other questions about that right now? Yeah.
How do you provide the testosterone? Topically or?
Well, you do the shots you can get every take once a week. The gel, most of the guys like the gel or the creams. So you just put them on. There's one called Androgel, which you just put on your skin and absorbs in about, it dries up in about 5 minutes or 3 minutes.
Which have you had the best luck with?
I'm sorry?
Which have you had the best luck with?
He said, what would you have the best luck with? And what kind of ways can you give it?
How do you?
Most of it's like the gels. Yeah, because they don't have a shot. Sometimes, you give a shot to one area. Sometimes people get little reactions to that, and it gets a little sore there all the time. So the gels are easy, but some guys don't like that because sometimes they'll stain their clothes. So you just play by. You just start with one and find out what works good for you. So you can use a number of different ways. It's pretty easy. I thought most of the guys like the gel, and that's it. Yeah.
If you've been diagnosed with cancer, should you
Oh,
stop to study?
Try again.
If you've been diagnosed with prostate cancer and you are on supplements, testosterone, should you stop?
I think before treatment, you probably should stop. Get your treatment, because then it cuts out a variable that you don't know how it's influencing anything, and you know where your baselines are and everything. Get treatment, and then when you know that everything is stable, your PSA is stable, your cancer is controlled, then get on the supplementation. Then there's no confusion. If you're in the middle of it and you get treatment and your PSA goes up, you're going, gosh, was that the testosterone I gave this guy, or was it the cancer recurring? And you get in kind of a dilemma there. So I prefer to have a little cleaner understanding of what's going on with the guy before I start. I want to make sure he doesn't have cancer. Okay? All right. Let's go on to the next subject. I know that there's all kinds of things we can talk about. Let's talk about this PSA screening controversy. Have anybody in this room not heard about the PSA screening controversy? I think most of you have, or read it in the papers about, and the basic message was that men shouldn't get PSA screening. Is that the message that you heard? Because that's the message I heard from the media. I wanted to, this was done by the U.S. Preventive Task Force. The task force is made up, is formed by the government and what they do is they ask these, not experts, a group of people to analyze particular screening objectives and the evidence for supporting it or not supporting it. And what I would like to do is go through this study a bit, and you can get this set for me too. In my explanation, I've just written up this whole thing. But I'd like to walk through this for you so that if you are talking to your relatives or you're pertinent to you personally, you know what to say about this, and it's pretty clear. And I will state right out front, I disagree. Some of it's personal, most of it, almost all of it is scientific. First is personal. My dad was diagnosed 68 years old in 1988 with prostate cancer at a PSA of 7.5. That's how he found it. He was a physician. PSA was just coming out. He was treated at that time, even though the year before, he had had a 5-vessel bypass surgery. Terrible cardiac status. He died this last year, 22 years later, of heart disease. No cancer. He would have been dead a long time ago. And that's my personal story. And others have told me similar stories about the fact that this is not a disease that you can completely, that I don't believe that you can completely ignore. And here's the problem. And here I want to go through what the problems with this study are. These are the top 5 reasons. First of all, there were no prostate experts on the study. To me, that's problematic, is that people who are making judgments for the care of men in this country with prostate, with or without prostate cancer, are making a judgment about how they should be managed, who've never walked with a man with metastatic prostate cancer through the last years of his life and understand what that means. I think that's a mistake. I think those should know what it's like, because it's not just about death, it's about the quality of life that people live too. And prostate cancer has a long natural history. Number 2, black men were not adequately represented. I think that was an inherent bias in this because black men typically have worse prognosis. So within our own population of this study, there was a whole group of people that weren't even represented at all. The report only dealt with mortality. Now mortality, I'm not going to dismiss as an important subject, but men can live a long time with prostate cancer. And these studies don't look at that aspect. So a man with disease who is suffering from his disease can be alive for 10 years, but this study would say that he wouldn't have benefited from treatment because he didn't die. Well, my dad's best friend had metastatic prostate cancer, just as a personal example again, had metastatic prostate cancer when he was diagnosed. And he lived 17 years. He would be considered to be a patient that, he would be considered to be in the mortality figures because he didn't die soon enough. These studies are only done like 8 years out. Men with prostate cancer can be affected by this disease in many ways. In terms of their urinary function, if it spreads to other areas, the treatments that they have to undergo, hormonal therapies and other things can affect the quality of life significantly. I think those of you who discuss this issue know that very, very well, and some of you may have had undergone it, so know that. We can't tell right now, when we have a diagnosis of a patient, who the person is that's not going to, that's going to be that person who develops disease that's systemic. We just don't have the tools quite adequately. We are working on it. But I don't think we should throw out everybody and not know what's going on. That's my personal feeling. I think it's a man's right to know what his status is and then make a reasoned decision, not just ignore it. And I'm concerned that there's a subtle movement of abandoning elderly patients because it's expensive to manage them. And maybe that's a bias. I don't know if it is, but I'm concerned about that. Because there's over 1 million people in this country that are over 100 years old now. And this is usually a disease of men in their late 60s. This report that's out there is a draft recommendation. It was not a final recommendation. It was subject to review by everybody, the public, including experts. I sent a rebuttal. Major organizations have sent in rebuttals. The final is not out. Yet everybody jumped on this, and even I saw it in Consumer Reports. I saw it in Time Magazine. These about statements about that men shouldn't get it. They make these statements way too early to be sensationalistic. And I think that does a tremendous. There's going to be men that die of this disease because of these statements. And people feel that they're heroic in the fact that they've saved some men from treatment. I don't think they're so heroic because there's going to be men that die of this disease because they didn't get their PSAs, or they think that they shouldn't, because they think they shouldn't. The study that was designed was not a study that actually was a study itself. It was a study of studies. It looked at the various literature in the world. There was 278 articles that they looked at. They only considered 5. They were randomized studies. Now, randomized studies are considered to be powerful studies because they're supposed to eliminate bias. 3 of the 5 studies were considered to be so poor that they couldn't make any sense of them or any judgment. 2 of the studies, one was American, one was European. Those were only considered to be fair studies. There was no good study. Now, those of you that are physicians in this room, or you know your physician, you would not make a medical decision that's important for a patient based on a fair study. None of us would. I was just amazed that they would make this kind of broad statement on a fair study. You have to have good studies. The problem with the American studies and the other studies was this. In the American study, half the patients had already been screened, which means they'd already weeded out some of the patients already that had prostate cancer. They didn't participate. Afterwards, patients still got PSAs, and those patients who got cancer early were treated. So you weren't really comparing a group that didn't have any screening and no treatment. You were comparing a patient group that had been screened to some degree, both before they entered and after they entered. So you're basically comparing the same group across the board. And the fact that this group, supposedly this panel, didn't recognize that, and that's why some of the other reviews of this said that's why it was only fair, that wasn't pointed out, to me was an appalling error. You have to have pure groups to be able to compare the results. So, I've got on here, I'll show you, you can read through this in detail. But here's what the media took this report to say, and this is how they say it. The problem with the media, of course, is they take stuff out of context a little bit, and then they sensationalize it slightly and dramatize it to make you read it. So it said here the PSA is a test because the blood test does not save lives. What the report actually said in the poor trials, in the two of the poor trials, due to the methodological limitations, the high risk of bias inherent in both these trials, the evidence was insufficient to support or refute the use of screening to reduce mortality. So those two studies said you can't make any judgment call. The Stockholm trial, which was all considered to be a poor trial, couldn't be generalized to the U.S. because the high PSA cutoff point and possible outdated treatments. So that one couldn't be included. And then, as I mentioned, the U.S. trial, this contamination issue, this issue of people getting PSAs before and after, they said, and people getting usual care during in a control group, that was also, they couldn't make anything from that. So the bottom line is there's no possible way they could make that kind of broad statement from that. They said that the PSA blood test leads to more tests and treatments that needlessly cause pain, impotence, and incontinence in many men. Well, needlessly is a retrospective view of something, all right? There's no question that any diagnostic test or treatment can, no matter what it is, no matter what problem, can cause a needless problem in hindsight. You can look back and say, oh, you know, I've got a blood draw today from my doctor, now I've got a bruise. That's a needless, somebody would call that a needless side effect. This is only determined later. And it's not known whether a treatment can cause a problem before treatment. So, for example, I had a patient that I treated that died 1 month after his treatment. He died of a heart attack. Everybody would agree in this room and said he got needlessly treated, right? He got needlessly treated. And then my dad, he got treated, had a bifacial bypass, and he went 22 years. I think my dad would say that he didn't get needlessly treated. So this kind of thing, it's meaningless. Here's another statement that was said, this is all in the New York Times, by the way. It said, sometimes 33 million men have had a PSA blood test, sometimes without their knowledge. How many in this room have gone to their doctor, the doctor's done some blood test, which you didn't know what he was getting? I think everybody in this room.
Women too.
Women too. Everybody has. So that's the kind of stuff, it's kind of like scaring. Well, yeah, my doc does stuff. He got, what's this CO2? What the hell do I need that for? You know? But these are screens, and if there was some problem there, he would explain it to me. But these are normal things that are done every day. But to say it like that sounds like, and somehow intentionally, doctors are trying to get this PSA on you. Like, come on. I don't know any doctor that does it like that. They're doing it to try to see if they can find an abnormality to help in your overall care. But they sound like that somehow somebody's out there trying to just grab blood from you and, without your knowledge. I do agree that you should explain tests to patients, though. This PSA test does not help distinguish between cancers that will or not affect a man during his lifetime. Well, PSA was not designed for that anyway. It doesn't tell you whether it's an aggressive cancer or not. But that sounds like that this has no use. You see, if I get crazy up here at the end of this, and I start going like John Belushi used to do, like going around like that, that's why stuff like that drives me nuts, because it has no meaning, and its intention is to get your attention and sound like something terrible is happening here. By doing this PSA, that's a terrible thing. PSA is basically the biopsy and other tests. You're looking at the grade, the stage, all this other stuff is designed to tell you how the cancer could behave, but not the PSA. It's one tool of it, but that's not what it's for. Prostate cancer expects more than 218,000 men each year, and 28,000 men die from it. That was a true statement. Thank you very much. One true statement. It's a good reason to find it early. This is the thing that maybe bothers me the most, is that some of these results that this group is actually coming up with may, in the very near future, become policy. It becomes policy in Medicare, it's going to become policy in your health care plan. I don't know if you know this, but your health care plan does not establish prices. Do you know that? You know who establishes prices? Medicare. You know what your medical care plan does? Just adds their component to it. They just put a percentage. So so they're not really concerned about all this, by the way, your healthcare plans. But the scariest part about this is that they may actually deny you. You deny men of having PSA tests. That to me it's mind-boggling, because that's where that's headed. This is where all this stuff is heading. Is try to reduce your ability to have this test as an option that's paid for. That you'd have to, so you make it pay for it yourself. And then this is what it was, just aside from PSA tests may not save them in high patients with fast-growing cancer because there's no proven benefit to earlier treatment of such invasive disease. That's the most ridiculous thing I've ever seen. I showed you just a minute ago. Here's the data out there. I don't think they looked at anything. Here's the guy that treated with surgery, averaging around, 30-40%? And here's the guys that got combined therapy up at 80 to 90%, out long term. These are guys with aggressive cancers, high-risk disease. There's so much data out there that they even make that statement. It's ridiculous. Like I said, excuse me if I get a little crazy about some of this stuff. It says here, can you show me?
1986 to 2005.
Oh,
1
yeah.
million. 1 million.
Oh yeah, 1 million men received surgery, radiation therapy who would not have been treated without the PSA test. And that sounds like we're, just treating people without. Yeah, that's probably true. But you know what? It found people earlier in their disease because of those. They probably wouldn't have gotten treatment. But that didn't say they didn't need treatment. It just said they wouldn't gotten treatment. It didn't say they didn't need treatment. But you see how those statements are made like that to make it sound like this is some kind of terrible thing that's happening to the American public?
What are they
Yeah.
trying? Are they trying to build up a case against the treatment because the treatment is expensive? Because the blood test can't be expensive.
It's like $50, $35 to $50.
Or they just, I hate to say it, are they just stupid?
Well, these are reporters who write this stuff up, but this is the sensationalistic idea, and I'm trying to balance that sensationalism with what really is. This is a statement: 5,000 died soon after surgery. Now we're talking about a 25-year period that they're looking at here, of millions of men who got treatment. The actual number was 5,000 over approximately 2 to 3 million treated. 16 to 0.16 to 0.25% of the men died after surgery. All right? After treatment. They didn't say they died from surgery. It's reported in the study, in the SEER studies, it's just they died soon after surgery. Like my guy who died after implant. They didn't say died from it. But that's the implication. You see the problem here? These little word phrases make it sound like, oh God, the surgery killing people. But when you look at the denominator on these things, they don't tell you that part. Yeah, you want to add a question?
Well, as I mentioned to you earlier, I went to 12 doctors, only one was planned to kill it.
Yeah.
What was the question, Dr. Grimm?
Have they ever studied people that are not,
Larry, hold up.
okay,
Nobody can hear you.
The question is, have they ever studied the numbers or percentages of men that do not show positive on a DRE, but yet after the PSA era, they've been shown to have prostate cancer? And if we did away with PSA, then this group of people that don't show any nodule would go untreated. That would have been me, and I would have probably found it years later after I did have a nodule, and it may have been too late. So how do you separate that subgroup of men that are benefiting from PSA?
That's the point. So guys are gonna, when I first got in practice, I mentioned to you this earlier today, when I first got in practice 25 years ago, the 5-year survival rate for prostate cancer was 69%. You know what it is today? Anybody know?
97.
That's exactly right, 95 to 97%. They should have a parade out here for the fact that we detected it early, we're treating early. Now, I would agree that some men don't need treatment. What I think our challenge will be in the next decade will be to find out who are those guys who don't need treatment. And there's some good things that are going on that are trying to figure that out. But right now, it's not perfect science. But yeah, I think we probably do treat some, we don't need to treat some people. But there's other people within that group that absolutely need treatment.
Why don't we focus in this war on prostate cancer on the other biomarkers and imaging techniques that can help establish who needs and who doesn't need.
I think that's what's coming down the line. I'm going to show you some imaging about that too.
I'll have to stop and check.
All right, thanks. Here they said 10,000 to 70,000 suffered serious complications. Now, assuming these were serious, of those 3.5 million, that means 0.28% to 2% had some serious complications. But when you just leave the number up there, it sounds terrible. But when it's only like 2%. But you know what the chance, if you take daily aspirin, of you having a serious complication of bleeding is? It's 1.5 to 2.5%. Now, was anybody in this room going to say, okay, we're going to cut out aspirin? No. So, this is, you know, all right. Okay, so and what did they made a comment about hormonal therapy, that there's no convincing that these drugs are helpful in localized prostate cancer. I disagree with that. There are some patients, there's a lot of patients, not just some, a lot of patients who do benefit from being on hormonal therapy for multiple reasons. They can delay therapy. It can be very beneficial in the management of patients. And many of you, some of you have been on those kind of regimens and know that. And so that kind of statement is just so ignorant of it that I am appalled by that. We use hormonal therapy to shrink the gland to help our treatments better. We put some patients who are on active surveillance on hormonal therapies to delay progression. There's all kinds of management reasons why you can use hormonal therapy successfully in a guy. You can use Avodar, which is a very localized kind of management of it. And so that shouldn't have even been said. And I thought that was really a detriment to a lot of guys who've had this. Okay, we talked about the studies. Okay, yeah, right. We talked about the studies already. 200,000, 300,000 suffered impotence, incontinence, or both. If you look at that look at the actual risk, that equals that is about 6%. It doesn't account, and that adds impotence, incontinence, or both. So that adds them together. So it doesn't account for the natural loss as well, so that would detract from that number. That's not a particularly high number considering the benefit. Now, that's including mostly surgery patients. The incontinence rate, for example, for seeds is less than 1%. It's like 0.7% of patients having to wear pads after seeds. So some of these are even lower. The impotence rates are even getting better about some of the strategies we have now. So this is kind of another scare number of sounds, making it sound like these treatments are so terrible. But I think those, not that I'm going to diminish complications, I don't, because I'm very serious about improving and decreasing the risk of any problem any patient has. But I think it makes it sound absolutely terrible. All right. I want to spend just a couple minutes on where we're heading.
Dr. Grimm, we don't have to stop unless you'd like to drink water.
Okay. Now, there's some exciting things that are going on in prostate cancer, particularly in seed implantation. One of them is on the diagnostic side of MRI. And this, again, we could have a whole discussion. I'm just going to show you just like on News at 11. MRI imaging over spectroscopic imaging, for example, or just plain CT imaging, or just plain MRI imaging. Multiparametric imaging is looking at the prostate in at least 6 or more different ways to look and see if there are lesions in there that's significant. Look what we call an index lesion. This may be a tool that we will be, I think, in probably 5 years. Some centers probably start sooner. My center, I'm trying to get started sooner, is that when you get a PSA that's elevated, you may be imaged first. And then the next step will be a directed biopsy to the areas of suspicion. I think that'll be our future. And then if we find something, there's a cancer, we may be able to choose just to follow that patient with imaging and not have any more biopsies. After that, good imaging and good biopsy done right up front. Right now, there's no imaging really. It's ultrasound, but ultrasound can't see lesions. It can help you, direct needles, but even that is not perfect, and it's not very precise, and it's not documented where the needle actually was. So I think that's where we're heading with it, and I think it's a very exciting area. The Europeans are really onto this. I've seen a lot of really unbelievable images, and of course that's always the best stuff, but here's what we dealt with, just to give you a couple examples. Here's the older MRI images that we used to get. They were kind of fuzzy, they didn't really tell you anything. Everything looked fairly homogeneous. This is a MRI image. This is a T2 weighted image in which you can see the peripheral zone here. Here's the central zone here. This shows some other examples. This is a patient I did just recently. I'm doing this also for planning my brachytherapy. You see this here? Everybody, can you guys see that there?
Yeah.
Big lesion sitting up there. Didn't even know about it. These are things that we're seeing now that we just never even knew about before. This is the anterior zone, as all as you know. Mari and I were talking a little bit earlier tonight, is that you don't biopsy that area. You don't even know about it. And sometimes you can't see the stuff on ultrasound. So that was an area we wanted to biopsy. This is a guy who had quite a, here's another area that didn't show up on ultrasound. I could feel him actually, this guy actually could feel. But see this area here? That's all tumor. So now I knew exactly where, when we planned the external beam and seeds, I had a very good notion of where the edges were and how far to push that margin out. Here's another problem, things that we don't even know about yet. I asked my radiologist, what is this? And urologist, what is this? Maybe you can help me out. But this is just beyond the prostate. There's a big fluid accumulation that's very similar to bladder, so there's some sort of accumulation of fluid there. They don't have the kind of answer for it. But I wonder about these things influencing the side effects. Is this going to affect his urinary function? Whatever. These are subtle things, and this is, we can now look at it when I do my planning for my brachytherapy now. Rather than just using just the ultrasound, I'm using a tool in which we can actually set up the MRI image exactly the way I'm going to do the implant, and then design it. And also I can see, I don't know if you can see, from there I can see right where the urethra is, and I can mark that in my planning and show what the dose is going to get to it. This guy had all the cysts down here, by the way, and outline this gland really nicely. And it is a real advantage to my ultrasound imaging. And it'll help me because, on that, but it's going to help me, the nerves that come around the prostate like this are, when they coalesce down here at the apex, and then they go into this region of the penis that's responsible for erections, you don't want to get those down in this area. So you want to be very precise, but down here, right in this last images, it gets real fuzzy because there's a lot of vessels there. In an ultrasound, you can't distinguish prostate from vessels. So we had a tendency in the past to broaden this area of the implant because we didn't know what we were treating completely. So I just, said, well, they're not hurting very much. I'll just add a little more volume there. I don't have to do that anymore. So the guys who are going to benefit are guys like Larry who had this treatment done like that. Very customized treatment. Is that okay to say, Larry? Okay. And so I can actually go through each one of these images and outline these things in transverse images.
These are all slices.
These are all slices through the gland, from a quarter centimeter slices all the way through the gland, so I can see these edges. So to me, this is kind of some of the exciting stuff that we're going to now. Not only are we going to be using it more for diagnostic purposes, but I'm going to use the same images to help me in my planning for the brachytherapy. Yeah, go ahead.
Wait. We're gonna have order, and I'll have the microphone over here as we usually do. And for the Q&A sessions, we'll ask you to line up and make your questions audible, because the rest of the audience wants to hear it also, and we can't when you mumble. So if are you ready for Q&A?
I'm ready, yeah, we're done with this part of it.
Okay.
We can go on and on, but
Anybody wants
I know we're going to run out of time.
Come on over here.
Oh, yeah, that's good. Try there.
I was just wondering where the color Doppler scan fits in the benefits compared to the MRI.
The colonoscopy.
The color Doppler scan.
Oh, color Doppler. I think it will still have some role. It does help you identify, areas of hypervascularity are indicated probably of a lesion. I think when you start combining with the MRI scan, I think it's complementary. So I don't use it normally because I'm going to treat the whole gland anyway when I do the implant. And I've only had like 6 local recurrences in my career. So I wouldn't direct actually more dose to that area particularly because of the color. But I know some of the guys do, and it probably helps them a little bit, at least direct biopsies. But we maybe use the MRI to do the same thing.
Thank you.
I realize that the number of seeds varies, but is there kind of a minimum and a maximum?
The number of seeds are based on the size of the gland, and every guy is different. Every guy has a custom plan based on his size and shape. So they have an ultrasound, they have all MRI scans now. We design a 3-dimensional model. We design where the seeds go, and we go into the operating room with that plan. And then we execute it. But the average range goes from anywhere from 50 to 150.
Thank you.
You mentioned that you wouldn't start testosterone therapy for about a year after treatment. What do you base that on? And is that a hard and fast?
No, I have a couple guys that started it right away. It impressed me so much because they had been on it before. The life was miserable without it, and I just explained to them the risk. But for my own personal management, I like to see a little more time to see what, because after seasons, PSA comes down rather slow, pretty quick in the first year. In the second year, you kind of get a pretty good idea. By the second year, you got a really good idea of how this is going to behave.
Thanks.
Could you address HDR versus LDR brachytherapy?
Yeah, when you look at, yes I can, thank you for asking that, because I'm a believer in HDR. HDR works real good, real well, and the techniques that are done and the people that do them, do a lot of them, do really get nice results. You will see on these slides, when you get them, there's some little squares in there that are HDR squares, and they're not too far off what we get with seed implantation.
Can you define those terms?
HDR is high dose rate radiation, where it's a temporary seed. Very good treatment. Little slightly different technique. The seeds are put in temporarily. They're then taken out a day later after several treatments. Yeah.
Doctor, I want to thank you. This has been one of the best presentations that I've heard, okay, since I've been a member here. So I want to thank you for, obviously you have a great passion for your work and you're very successful. So thank you for sharing your insights with us. My question is, you indicated that there was 6 or 7 people that unfortunately had reoccurrent.
Yeah.
How did you deal with that generally? In the context of how do you determine where that cancer is?
Right.
And then how do you...
Well, the first guys who occurred a number of years ago, I didn't know. We just went and random like we do now. Just kind of go and sample biopsy and see where it is. That's changing. Now the guys I've done, one guy that I had this last year, he had his PSA just hung around 3 to 4. Wouldn't go up, wouldn't go down, just stayed there. So we're just kind of concerned. So we did an MRI on him. We found a very localized area in his prostate that was cancer that we biopsy proved after imaging. We then went in and did cryotherapy on that. And his PSA went absolutely 0.
So
So I suspect that's probably how we'll do things in the future.
the follow-up question, what kind of imaging? Was it a T1 mag, a T2,
The
T3?
multi-parametric. Just like we did all of those. We did we did a T1, we did a T2, we did what they call a dynamic contrast enhancement, and ADs, what they call another one called an ADC, which is the diffusing coefficient scan. So we did every way we went loose. We did transverse, we did sagittal, we did coronal images. We probably had 400 images on this guy.
So in all cases, were you able to, you mentioned there were 6 cases, were you able to identify your local?
No, that's just this one guy. The other guys were years ago.
Yeah, okay.
So usually what I used to say to patients is get a radical prostatectomy by Mark Watson, who's at City Hope, because he's one of the few people who can do that surgery. Most people hear when they hear from surgeons, well, if you have those seizures, you have a recurrence, you're never going to have surgery. But that's not true. It's just that surgeon can't do it. But he doesn't have the ego to say that I can't do it. So he says it can't be done. But the reality is it can't be done by a competent surgeon.
Thank you very much.
Yeah.
Well, for high-dose radiation, could you tell us about some artists in the field?
Can I tell you about some artists in the field?
Yes.
Like who's who in the zoo?
Yeah.
I'll be glad to say that. Why don't you email me about that, because I can give you a whole list of people. There's good people all over the place. And actually, people here, Steve Doggett's here in your neighborhood here. He does a good job.
Does he know?
Yeah.
I thought he did permanent.
Did you say low dose rate or did you say high dose
No,
rate?
high dose.
I'd probably go to UCLA.
Okay.
Yeah. If you're going to have high dose rate.
You use cesium 123.
I have. We've done it in some patients. Cesium, gives up its energy. Cesium is another isotope that's used as similar dosimetry characteristics to iodine and palladium in terms of its amount of radiation it gives. It gives it up very fast. 9 days is its half-life. The first patient I gave to it was a vice president of the company, who was very enthusiastic, much more enthusiastic than I was about it, of course, as you can imagine. And I didn't really like his symptom complex after he got up here. He had pretty high obstructive issues, and much more intense. And
Has more energy, I believe, right?
The reality is this. First of all, the first question is this isotope going to result in better local control? Number one. Answer is no. It can't. The local control is too high now. You'd have to have 20,000 patients to notice the difference because of the failure rates are so low. I mean, to me, it's 0.7% in the literature. In my center, it's even lower. Okay? So, there's no benefit there. The next question would be, is it going to change the side effect profile? And the answer is probably not, because it's given, the prescription is the same radiobiological dose as the other two isotopes. The same thing. You're given the same dose. So the effect shouldn't be any different. Now, the sell point is they say that it's going to be a lower dose, but that doesn't mean anything because it's given at a higher rate, because it's given the same biological dose. So, now, here's the thing. Once some of these issues of dose get worked out and they find out what a good dose is for that isotope, I think it'll be just as effective as the other two and be just as safe.
I was just wondering, what condition is the prostrate left in after the seed therapy? I mean, my doctor said something about it collapses a little bit or something, it flattens a little bit, or what?
The best example, I guess, analogy I could give you,
Yeah.
you put a tangerine out in the sun or leave it out, open it up a month later and look inside, you're not going to see any cells. All you're going to see is the matrix. That's basically what this does. It's soft. But the important for function is to have those girders in there, that matrix, to support the urethra. That's the critical aspect of urinary control. If the urethra, which keeps everything tight until you want to urinate, is the reason we don't leak on ourselves. So you have to have a structure around it.
There will be some semen reduction, right?
Yes, absolutely. Yeah, almost all guys get semen reduction. Almost all guys can climb it. So that's a good thing. One thing I make sure guys do afterwards is I put them on if their erection abilities go down, I put them on an exercise program. Want to guess what that exercise program is? Erections. They're recommended to get, and no matter what treatment they get, they go on an exercise program at my center. If their erections are not quite as good, they get stimulated erection 3 or more times a week. And a lot of them go on daily Cialis. But to get the idea of after any of these treatments, because they all of them can affect ability, is to keep that nerve and vessels healthy.
Okay, thank you.
Yeah, sure.
In the low and medium risk studies that you showed where prostatectomy was lower than the other two, was that just the nerve sparing that it was considering? Because it has the most risk for leaving positive margins.
Now say that again to me, the robotic surgery, are you trying to make a distinction between robotic surgery and the other surgery? Or?
No, you showed brachytherapy versus
Oh, yeah,
surgery.
yeah.
And the prostatectomy showed the lowest of
Yes.
the survivability long term.
Cancer
And
control.
Did you mention that was just nerve-sparing type prostatectomies? 'Cause
No, those weren't all nerve-sparing surgeries. So nerve-sparing surgery is probably going to do slightly, if you just had looked at a pure group of nerve-sparing, that didn't distinguish that. We just said radical prostatectomies. The studies typically don't sort that out clearly. Most, however, in the United States, in low-risk disease, 90% of robotic surgeries done today are nerve-sparing.
Right. Which have the higher potential for leaving positive margins.
That's correct.
So that will skew that particular
It may.
therapy.
I would say I haven't seen any studies that looked at this in the robotic era, so I'm kind of wondering.
Yeah.
As I said before, if there's no data out there, that should raise a red flag. Because if it was good, you can bet your life somebody would be waving the flag saying how wonderful we are.
Yeah.
So that's what you just got to be careful about. So if you don't see something,
But men always have a tendency to want to choose something that's more beneficial in terms of the side effects, lesser side effects. And in radical, the nerve sparing, but the big push is that you won't have any impact to your impotence or the incontinence.
that's not true at all.
I'm sorry, to the
The surgery comparison studies to date have looked at robotic versus standard radical prostatectomy showed no difference in cancer control rates, impotency rates, or incontinence rates. Although I will qualify that by saying there's a few studies that showed a little bit better impotency rates. I'm not sure quite, couldn't really sort out whether that was a better patient group or what. But it's pretty darn close. And if you think about it for a minute, the surgeries are basically surgery. But the robotic surgery is a much better technical surgery. So patients are getting out of the hospital earlier, they're less bleeding, that sort of thing, less pain. And so it is better that way. But the other factors hasn't been proven yet. If you find something to that, let me know. Okay?
great, thanks.
Thanks a lot.
I had a seed implant 15 months ago with Dr. Doggett,
Yeah.
and after 6 months, my PSA was 1.7, and after 12 months, it was 4.5. Can you talk a little bit about how common the PSA bounces?
Yeah, we said it was one of the first things I learned about. PSA bounce occurs generally between 12 and 18 months after radiation, whether it be external radiation or Caesar. It occurs in both groups. And we feel that its explanation is not really completely clear, but some people have speculated that as these cells die, your cancer cells and normal cells die, they release a substance called cytokines. Cytokines cause a reaction, an inflammatory reaction in the prostate gland, which is an inflammatory process, which we know increases PSA levels. Now, typically what you'll see when you see a bounce, 87% of the patients that we looked at that had something like you, subsequently what it would do is, normal behavior was about for 4 to 6 months, it would stay sort of elevated, then it start creeping back down. Now, sometimes there can be related to, there can be an infection in there, so we put people on antibiotics. There can be an anti-inflammatory effect, so we put them on a non-steroidal like Aleve or something like that. And all these things, and the PSA will drop down with that, so that's a clue. But we monitor the guys closely when the PSA rises. But almost all the time, it's going to come back down.
In my case, I have had 2 urinary tract infections over the last 14 months, which I never had any problems with that before the treatment. 2 in 14 months, I guess, isn't a lot, but it might have impacted my PSA.
Probably, yeah. And you find an antibiotic that works. And stay on it. What I found is that it usually, when those situations like that, it was important to keep the guys on the antibiotic course a little bit longer, like 3 to 4 weeks rather than a 10-day, 2-week course. Because usually the bug, it didn't really completely eradicate it on the short courses. So you might look at that.
Thank you.
Doctor, a couple quick things and then we'll wrap up. Why don't you give our audience just a few little indications, some of the advances that you personally, you spoke about them earlier, the gauge of the needles and the stringing and anything else that you've done that's an innovation that's making brachytherapy a little bit better now than maybe it was several years ago.
Oh, thanks. One of the things I've enjoyed about my career is I've had the opportunity to do a number of innovations. I'm kind of I like to get in the shop and do things. And one of the nice things about implantation is that the seeds we're using now are smaller. And so about half of my guys that I can treat with iodine, all the guys that I can treat with iodine, I treat with a new product called Thin Strand. Now, Thin Strand, what it is into a 20-gauge needle. Now, needles are like shotguns with this. That's not really going to happen. But as the gauge goes up, this needle gets smaller. So a 20-gauge is smaller than an 18-gauge needle. So now I'm using an 18, like for Larry, I used a connected seed in a 20-gauge needle. Well, Larry told you this. He told you that his post-op course is typical. Hardly any pain, any bleeding. And so I've been really, really pleased about that.
Do something about that darn catheter, will you?
Yeah, the first urinations, the fees are referring to the first urinations sting like heck. And it's because we look in the bladder, check it out, and the first few, they sting pretty good. That's what most of the guys can remember rather distinctly. I'm working with this company to now start to meld these MRI images with the ultrasound images to do better planning for and do intraoperative calculations of dose. And so that'll be coming on in the next 6 to 12 months. So I'm kind of excited about that and see how that works. And we have a new marker, an MRI marker, so we're going to probably be doing that work with Steve Frank at MD Anderson. And we've developed a marker that can be seen on MRI imaging. Right now we can't use MRI imaging for post-operative evaluation because the seeds throw off a weird distortion. So that'll solve that problem, so we'll be able to actually do MR on a very good image of the prostate and a good image of the seeds. So that's coming down the line too, and we need FDA approval for that, of course. So these are kind of the fun things that I think are going to make this even better.
Okay, last question, and I ask this of a lot of folks that come through. Are you aware of any promising therapies on the horizon outside of radiation or even within radiation? Is there anything we can look forward to the next period of time that will be innovative and new and effective?
I just hope we don't regress. I think probably what you guys can do the most is to get out to your family and friends and relatives that do not abandon the PSA and make sure that your physicians, some of the primary physicians feel very strong, have adopted this stuff and feel that they're being saviors to the patients by not doing PSAs, but I don't see it that way. And I'm afraid that a lot of people are going to be diagnosed very late and we're going to have to get more aggressive with their therapies and then consequently they're going to have more side effects. But everybody should be like Larry and some of you have just seeds alone. Get them very early in treatment, and you have a pretty normal life. I'm not going to get into people's personal sexual life, but we get into that function too. That's generally pretty good with after seeds. So what can you ask for? There's been no deaths. We've done over 10,000 patients with seeds, for example. There's been no deaths and no infections. Immediate infections afterwards. So you get urinary infections occasionally, like he said, but those are minor and they get easily treated. So I think it's a small price to pay for curative treatment. So I think, but still, we got to get it early.
I have two final questions. One is, you spoke about cesium and iodine. What are your criteria for choosing which isotope is appropriate for the patient?
You're going to see that a discussion about that in the next newsletter, PCRI.
Okay.
Because I just sent it in this week. But basically, the studies have shown that there's really no difference in cancer control for either of the isotopes. So some of this is a personal preference by the physician. Before, we selected palladium for more higher grade cancers, 8s, 9s, and 10s, all got palladium. If you're using a combination of therapies, we generally use palladium because it gives the opportunity quicker, then we can start the external radiation later. So some of it's technical, some of it's just logistic.
The last one is, do you have an opinion you'd care to share on why the task force, with the flaws that you demonstrated in the presentation, could come to that kind of conclusion, which seems to be biased, erroneous, and maybe has an ulterior motive?
I'm totally baffled by this. I don't know whether there's some other agenda going on. I will tell you this. I'll give you another example for another recommendation and another example of how these things kind of can fail the system. I think they're primarily motivated because of the cost of these screenings, and there's kind of a pressure to find a reason not to do screening. My father-in-law was diagnosed with prostate cancer 8 years ago. I don't get into his medical care typically, but we treated him, my partner treated him. His prostate cancer is fine. This last year, he developed a fist-sized colon cancer. And I asked him, I said, well, did you have a colonoscopy in the last 8 years? He said, no. I said, well, why not? He says, because I was over 75, my primary physician said I should never have one again, because that's what the preventative task force said. Now this guy is 86 years old now. He plays golf every single day during the summertime. Healthy as a horse. And I'm just going, people are not thinking here. His mother lived to 98. He's gonna outlive that. And I think that sort of senseless, not thinking kind of management of patients is not right. Fortunately, he got through surgery, but he's got about a 50-50 chance. And he could have been totally cured by a colonoscopy years ago with no risk to him.
Well, we've kept you a long time. Very much appreciative. An excellent presentation.
Thank you very much.
Come all the way. Have your coffee or lemonade or whatever.
Thank you.
Thank you all. Thank you all for coming. We're adjourned. Dr. Grimm has agreed to meet in the foyer for a little while more. Just need to get some rest if you still want to commune with him. Not up here.
Thanks.